Hello everyone, welcome to the Admitted Student Day. My name is Mousumi Banerjee. I am a research professor in the Department of Biostatistics at the University of Michigan School of Public Health. I am also the Director of Biostatistics at the Center for Healthcare Outcomes and Policy at the U. It's my honor and my pleasure to talk to you about my research. But before that, I wanted to give you a glimpse of my journey to this point. I grew up roughly about 8,000 miles far from where I currently live in Ann Arbor, and I grew up in Kolkata, in the eastern part of India, which is one of the most populous cities in the world. Roughly population is about 5.2 million. And I did my high school and my undergraduate and my master's degree in India. Since childhood, I had this fascination about numbers. And frankly speaking, I don't know where it came from, because my family was in the liberal arts. My father was a professor of English literature and my mother taught languages in middle school. But I love numbers, and it was really one of my high school teachers who kind of showed me the beauty in math. Calculus was my favorite subject, and the concept of limit going to infinity just fascinated me. So anyway, by the time I left high school, I was converted. I mean, I knew that whatever I did, it had to be involving numbers and mathematics. So at the same time, my childhood was a bit unusual. Around the age of 7 years, I had encephalitis and I almost died. So I had this tremendous urge also to do something in the health sciences field, and I really didn't have a clue of what the right combination would be. So I went to get my undergraduate degree, my bachelor's degree at the Indian Statistical Institute. But my training was very much in the theoretical foundations of statistics, and I really didn't know how to tackle data. So when I came to grad school in the United States at the University of Wisconsin, I knew all about the theory of linear models, but I didn't know how to fit a linear model. Basically, data just made me nervous, and I didn't know how to kind of make sense of data or uncover patterns from the data. Wisconsin really gave me a sense of statistics as an applied science. And along with the solid education that I got, and also like the first flavor of what it means to do research, besides that, I also thought that because of the outstanding cohort of graduate students from all around the world, it exposed me to the beauty of doing science as a team. And I learned that you do science together. So, people come from different paths, and there are maybe shorts and bends in your journey, but you follow your dream. So, what are some of the broad themes in my research? As I mentioned, the primary driving factor in my research all throughout my career has been the motivation to impact human health and healthcare, and ultimately doing science that has an impact on policy. So I work in the area of clinical decision making, healthcare delivery, studying health outcomes, disparities of healthcare delivery and outcomes in the population, and again, ultimately, that has an impact on policy changes. So some of the the salient features of the kinds of data that I use in my research are population-based disease registries, big data, electronic health records, claims data linked with disease registries, and so I have been very much involved in integrating data from different EHR platforms to again understand healthcare delivery and outcomes in the population. So as you can imagine, because I deal with observational data, so the statistical issues and the challenges are manifold. So issues like confounding, then multi-level data in the sense of patients are nested within physicians, physicians are nested within healthcare systems are kind of nested within geographical areas. So sort of the multi-level structure of the data, missing data, misclassification and misattribution in EHR. So these are some of the statistical issues and challenges that we confront. And my methods research has been in the areas of developing machine learning type of methods for understanding healthcare delivery, correlated data methods, survival analysis, causal inference, and applications of these primarily in the area of cancer and pediatric heart diseases. My work in the area of disease prognostication has been to develop these clinical decision-making tools using machine learning type of methods. I have done, along with my graduate students and research assistants, a lot of work on developing tree-based and ensemble type methods for prognosticating breast cancer, thyroid cancer, kidney cancer patients. And typically the idea is how do you integrate clinical characteristics, tumor-related characteristics, biomarker information into a clinical decision-making tool that will help physicians to make decisions about prognosis. The second broad theme of my research is understanding cancer care delivery and outcomes in the population. So towards that end, I use data from national cancer registries such as the surveillance epidemiology and the end results registry from the National Cancer Institute, linked with Medicare claims data to understand the impact of overtreatment in the population, and in terms of like provider and access issues. So for example, in a study published in the Journal of the American Medical Association, we looked at the use of radioactive iodine for thyroid cancer, and what we saw using data from the National Cancer database, which tracks information from 1,400 hospitals in the US, we saw that there is large overuse as well as underuse, or in other words, although there are clinical guidelines, but in the population, they are not being sort of quote unquote implemented or followed the way they should be. So there is lots of heterogeneity in the use of radioactive iodine for thyroid cancer. In a study with kidney cancer patients, we were looking at the diffusion of novel surgical modalities in the population, and once again there we saw that there is tremendous variation, and it really matters where you go. I mean, it's kind of scary because given the disease, no matter whether you go to hospital A versus B versus C, given the disease characteristics and the patient characteristics, you would expect that you get kind of quote unquote the same treatment. But it turns out that that is not the case, and it really matters where you go. And then finally, in a study that we published in the British Medical Journal, what we saw is that with the advent of technology, there are more and more imaging tests and other sort of diagnostic tests that are being done. And in the case of thyroid cancer, this has led to much more treatment for perceived recurrence, but with no downstream implications on improving survival. So these are examples of some of the work in the area of health services research and outcomes research. Once again, observational data from large disease registries and trying to tackle the issues of, multi-level modeling, confounding, and using, mixed models type of regression framework, multi-level models, partitioned variances at different levels of provider, hospital, and patients, and really trying to understand what is happening in the population. So I'm going to talk very briefly about another area of my research, and this is I spent most of my career in the area of cancer, and for the last 5-6 years, I have been working with this pediatric cardiac critical care network, which is a collaborative of 50 hospitals, mostly across North America, but also in Europe and Asia. Although we are interested in kind of looking at the quality of care delivery in the population, but there are many clinical challenges that clinicians have to confront. These are patients who are extremely sick, and they undergo very critical heart surgeries very early in their life, and clinicians are often challenged with balancing mechanical ventilation time with extubation failure. So in the pediatric ICU. As is known from the literature, extubation failure may lead to downstream complications. So there are tremendous knowledge gaps among hospitals in terms of extubation readiness, meaning when is the right window to extubate these children, because while you want to be safe, but at the same time you don't want the kids to be on the tube for a prolonged time, which might affect downstream outcomes. So we come across questions like this, and in an effort to improve practice in the ICU, what we are doing is we are integrating data from different platforms. We have data from the Pediatric Cardiac Critical Care Consortium, the PC4 consortium. It's a clinical registry. It's big data, large data, but shallow data in the sense the variables that are captured in this registry are variables that all hospitals can uniformly collect data on. Along with that, we have also data from ICU monitors. So high resolution physiologic data that are continuously streamed every 1 minute from the ICU monitors. These are institution specific data sets. These are small but deep data, high dimensional data. So the challenge has been from and the work that we are doing is to develop a prediction tool using this large scale shallow PC4 data and the small scale deep T3 data in tandem to ultimately improve the prediction of extubation failure in these critically ill children. So as you can imagine, it's kind of like a sort of the work has developed into combining time series type of methods with machine learning to ultimately develop a prediction tool that can be used in the real-time setting for clinical care of these very, very sick children. Finally, just to give you a glimpse of a recent work that that sort of touches on the policy side of things, So this is a study with my colleagues in neurology looking at the out-of-pocket costs for commonly prescribed neurologic medications. And we used a large privately insured claims database from United Healthcare over a span of 15 years, 73 million patients in the database. And what we showed is that alarmingly that the out-of-pocket costs has increased like almost 20 times for some of these prescribed, commonly prescribed neurologic medications. Bernie Sanders tweeted about our study, and this is one example of where our research has been on the forefront of perhaps making policy changes. So the other hat that I wear is I have worked in the area of global public health and focusing on low and middle income countries. And we have been involved in developing appropriate screening and prevention strategies for diseases using low resources. And I have collaborations in India. I'm involved with the cervical cancer screening program in India, and in Bangladesh, I'm working with the National Cancer Institute of the country and trying to develop appropriate surveillance and registration for cancer cases in the country. I also have projects in maternal and child health in Bangladesh. Through the Office of the Global Public Health at the School of Public Health here in Michigan, I send student interns to these countries and to be involved in my research in these areas. I want to thank my awesome collaborators. Michigan is a rich, intellectually a very rich place. And I feel honored and privileged to be working with some of the tremendous scientists and tremendously accomplished scientists. I only have pictures of folks with whom I have written at least 5 papers and at least 2 grants, but they all enrich my life as a researcher, as a scientist. And I believe that my graduate students and my research assistants who work with me also get very enriched through these collaborations. And talking about students, I feel I'm blessed to have extremely talented students from the Biostat graduate program, research assistants, research analysts at the Center for Healthcare Outcomes and Policy who support and enrich my research every day. So together with my wonderful colleagues and graduate students and research staff, we are doing science together and ultimately trying to impact human health and healthcare. Thank you, and hope you choose the right path and follow your dreams.